welcome to Grand Rounds. Yeah. We have the pleasure today to welcome one of our surgery chief residents here at ECU, Dr. Michael McNally. He recently gave this lecture to the surgery Grand Rounds, and it was so well received that we snatched him up for ourselves. Dr. McNally did his medical training at the University of Texas in Houston before coming to North Carolina to do his surgery residency. He's currently in his 6th year and one of their chief surgery residents. He's well versed in the field of vascular surgery, in which this talk is based. He's been involved in several publications in the field, and in fact, he will be continuing his training in Gainesville at the University of Florida in vascular surgery. He leaves in a couple weeks, actually. The topic today is DVTs, which hits homes for a lot of the people here. We either know a patient with a DVT, we've treated them, or are currently treating someone. So without further waiting, Dr. McNally.
Thanks, Daphne. And thank you, Dr. Dolens, and members of the department. Like Daphne mentioned, I gave this talk last week at the Department of Surgery Grand Rounds because each graduating surgery residents are required to give one presentation before leaving. So after completing my talk last week and having a sigh of relief after some anxiety of public speaking, Dr. Bogey patted me in the back and said, "You're on for next Friday at 8. I said, "Thank you, sir." So here I am. So why this topic and title? I chose this topic for several reasons. I wanted a topic that was a common medical condition across all surgical subspecialties. A second reason was one of the first patients I ever took care of in this hospital was an elderly woman who was admitted with a GI bleed and had an extensive hospital stay requiring several surgeries. The day I went to discharge her several weeks into her hospital stay in my intern year, she literally was transferring to the wheelchair to be wheeled to her car, and she had a code events. She died later that day with a massive pulmonary embolism. And finally, on a personal note, I married into this crazy family with multiple inherited hypercoagable states, all inherited from my father-in-law. My wife is the youngest of 7 children, 6 of them being girls, all of which have been tested have the factor V Leiden mutation. Specifically, my wife inherited factor V mutation, protein C deficiency, and has a methyl tetrahydrate folate reductase enzyme defect resulting in hyperhomocystinemia. So the reason we discovered a number of these was after undergoing a pretty extensive workup after several miscarriages early in our marriage, and has definitely impacted a number of her pregnancies and our bank account with therapeutic Lovenox treatment throughout her pregnancies. So, and as for the title, we spend a lot of time at our house practicing the ABCs and learning to read these days, but obviously my wife does a much better job than I do. You have to forgive me, but one of the traditions of surgical grand rounds for the chief residents include a couple family photos as well, so they will be sprinkled throughout this presentation. My topic today will specifically not address chronic venous insufficiency, varicose veins, and although mentioned in this talk, but will not discuss in depth pulmonary embolism. So the objectives of this talk are to describe why this topic is important and relevant in healthcare today, review the pathophysiology, risk factors, and methods of diagnosis, discuss current recommended DVT management, including available medical, surgical, and catheter-based interventions, and finally review the recently released DVT Prevention and Management Guidelines. This is our first child, Morgan, as a toddler. The precise definition of the incidence of acute DVT is complicated by the clinically silent nature of thromboses in hospitalized patients, as well as by the nonspecific signs and symptoms. Most clinical trials and studies on the incidence of acute DVT have focused on specific inpatient groups, such as postoperative patients. Community-based studies provide a good estimate of the overall prevalence, however, frequently lack objective documentation of the DVT. Kuhn and Associates calculated the incidence of 250,000 cases of acute DVT per year in the United States. However, the results were based mainly from questionnaires and clinical findings suggestive of previous DVT. Community-based studies of venographically documented symptomatic DVT have reported a yearly incidence of up to 1.6 per 1,000 residents. And Silverstein and colleagues estimated 201 100,000 new cases of venous thromboembolism occurring annually in this country, of which 107,000 were attributed from DVT alone. Untreated or inadequately treated DVT can lead to severe complications. An untreated iliofemoral venous thrombosis is associated with as high as a 10% risk of fatal pulmonary embolism and at least a 50% risk of a pulmonary embolism or recurrent venous thrombosis. Furthermore, post-thrombotic syndrome is a lifelong condition resulting in painful lower extremities, disfiguring skin changes, ulceration, and potentially debilitating state. Although few data exist on the overall economic burden of DVT and sequelae, the sheer number of patients affected and the known consequences of thromboembolic events point to substantial healthcare burden. A 2002 study conducted from a managed care perspective predicted that the U.S. national annual expenditure on DVT events, excluding physician charges, amount to $1.5 billion. According to the U.S. Department of Health and Human Services, the Agency for Healthcare Research and Quality claims the incremental length of stay and cost of treating a case of preventable venous thromboembolism or event is substantial. The AHRQ Healthcare Cost and Utilization Project estimated an incremental inpatient cost of $10,000 per DVT and $20,000 per pulmonary embolus. This is our second child, Peyton. The earliest mention of venous anatomy and surgery dates back to around 1550 BC, where the first written record of varicose veins and suggestion of treatment were recorded in the Ebers Papyrus. Extensive description of venous ulceration was found in the work of Hippocrates, and he noted in his work titled De Ulceribus that incisions around large ulcers do not heal well and suggested puncturing the ulcer to stimulate healing. There are numerous citations in history between the 1st and 2nd centuries, including the writings of Galen, for the ligation of blood vessels to treat venous disease. Skip forward several centuries, and the interest in venous anatomy can be seen in numerous pieces of artwork. In the 15th century, the picture on the left illustrates the anatomy of veins by Leonardo da Vinci, and not long afterwards, the anatomy of the venous system was presented in great detail in the works of André Versluius. Accurate reports on acute venous thrombosis were published much later than the earlier descriptions of varicosities. It was not until 1810 that Ferrier described a patient with Phlegmasia Alba Dolens, but he presumed the condition was caused by lymphatic obstruction. The relationship between Phlegmasia Alba Dolens and acute venous thrombosis was established by Davis in 1822. And in his famous writing in 1859, German pathologist Rudolf Virchow described his revolutionary discovery of the 3 main causes of DVT. The illustration taken from his work shows venous thrombi protruding into a deep vein from side branches. His depiction of thrombus in the deep veins completely changed the understanding of DVT. Virchow first proposed the key 3 factors in the development of venous thrombosis. These 3 tenets, although refined and of variable importance depending on the individual, remain today as the foundation to our understanding of venous thrombosis. In general, blood flow abnormalities determine the localization of venous thrombi. Abnormalities of the blood may include variants of both the coagulation and fibrinolytic systems. And finally, biologic injury to the venous endothelium is potentially more important than gross trauma. The activation of the coagulation cascade is critical in the pathogenesis of DVT. The coagulation cascade functions through serial activation of zymogens in the intrinsic and extrinsic pathways, with ultimate generation of thrombin by the prothrombinase complex. Antithrombin and the thrombomodulin protein C systems are the primary inhibitors of coagulation, whereas the fibrinolytic system serves to further limit fibrin deposition. A pre-thrombotic state can result from an imbalance in these activators or inhibitors of coagulation and fibrinolysis. The second component, vessel wall injury, encompasses both mechanical and biochemical venous injury. Mechanical injury includes direct venous trauma, such as hip arthroplasty or central venous catheters, the #1 cause of upper extremity DVT. On a more microscopic level involving biochemical injury, the normal endothelium is antithrombotic, producing prostaglandin I2, antithrombin, thrombomodulin, and tissue-type plasminogen activator. However, it has the potential to become prothrombotic, producing tissue factor, von Willebrand factor, and fibronectin. In addition, greater endothelial permeability and leukocyte adhesion have been demonstrated in response to distant surgical injury. Therefore, the induction of procoagulant activity, the suppression of normal antithrombotic mechanisms, and the exposure of neutrophil receptor ligands all contribute for clotting potential at the endothelial level. The third factor in DVT etiology is a low flow state. Several mechanisms are proposed to explain this factor. In comparison with pulsatile flow, static streamline flow is associated with profound hypoxia at the depths of venous valve cusps, which can induce endothelial injury. The effect of hypoxia on cultured endothelial cells leads to the stimulation of cytokine production and leukocyte adhesion molecule expression, accounting for adhesion and migration of leukocytes in stasis. Stasis also allows for the accumulation of activated coagulation factors and the consumption of inhibitors at sites prone to thrombosis. And finally, stasis in large veins provides a low surface to volume ratio that prevents interaction of normal antithrombotic venous endothelium, already mentioned. In summary, this is a dynamic, multifactorial process with convergence of 3 pathologic factors to produce a thrombotic event. Height and colleagues identified the following independent risk factors for developing a DVT, which include increasing age, male gender, surgery, trauma, hospital or nursing home confinement, malignancy, neurologic disease with extremity paresis, central venous catheters or transvenous pacemaker, prior superficial vein thrombosis, and varicose veins. Among women, risk factors include pregnancy, oral contraceptives, and hormone replacement therapy. Here's a more complete and clear list of the independent DVT risk factors. I've highlighted several of these risk factors that I want to mention in particular. DVT is consistently seen with a higher incidence with advanced age, secondary to higher levels of thrombin activation markers, as well as anatomic changes to the soleal veins, with more pronounced stasis in the venous valve pockets. One study by Hansen and colleagues found the prevalence of thromboembolic events among men to increase from 0.5% at age 50 to 3.5% by age 80. In pregnancy, DVT risk increases secondary to a pre-thrombotic state with increased fibrinogen, factors 2, 7, 8, 10, protein S, as well as impaired venous flow by uterine compression. Inherited thrombophilias, like I mentioned in my wife's case, are an additional risk to pregnancy, resulting in a 4% complication rate in this population, necessitating anticoagulation throughout the pregnancy. And of the list of primary hypercoagulable states, factor V Leiden is the most common inheritable trait. For central venous catheters, 65% of upper extremity DVTs can be attributed to central venous cannulation, although the incidence of symptomatic thrombosis is much lower. Interestingly, the risk includes femoral venous catheters, as described by Meredith et al. In Journal of Trauma, which showed ipsilateral thrombosis developing in 12% of patients with large bore catheters for trauma resuscitation. The clinical presentation of acute DVT may vary, or does vary, from the absence of symptoms to massive swelling and cyanosis with impending venous gangrene, as in the case of Phlegmasia, Cerulea, Dolens. The most common signs and symptoms are listed above. Unfortunately, the diagnosis of DVT based solely on the clinical signs and symptoms is notoriously inaccurate. 3 separate studies in the 1990s note patients referred to the vascular laboratories for exclusion of DVT showed results of their ultrasonography were positive in only 12 to 31%. Important on the clinical spectrum of the DVT presentation is Phlegmasia Alba Dolens and Phlegmasia Cerulea Dolens. Both involve extensive iliofemoral thrombosis. Phlegmasia Alba Dolens literally means painful white edema. Historically, it was referred to as milk or white leg, from it commonly being seen in pregnancy in mothers who had just given birth. There's a total occlusion of the deep venous system with an open superficial venous system. The common presentation is a pale, painful, edematous extremity with blanching. Conservative initial treatment is recommended. Further down the DVT spectrum is Phlegmasia Cerulea Dolens. There's an occlusion of both the deep and collateral venous systems, resulting in a painful, massively edematous cyanotic extremity. Therapy was more aggressive with anticoagulation and thrombolysis as opposed to thrombectomy due to a very high rate of rethrombosis. When talking about DVT presentation and clinical evaluation, one specific anatomic cause of DVT is the condition May-Thurner Syndrome. named after physicians R. May and J. Thurner, who described the condition in their 1957 article in Angiology. This left lower extremity DVT stems from compression of the left iliac vein by the right iliac artery. It is classically seen in women ages 20 to 40, and the diagnosis is confirmed with venography. Treatment involves balloon angioplasty and left iliac stent placement, usually after thrombolysis. There are various modalities to diagnose DVT. Several historic modalities include IPG, radiolabeled fibrinogen, and thermography, which was based on the observation that a DVT typically raised skin surface temperature 1 degree Celsius that was detected with instruments incorporating infrared or liquid crystal technology. Contrast venography has historically been the gold standard for the diagnosis of acute DVT. However, significant limitations such as unsuccessful venipuncture, inadequate venous opacification, and contrast allergies, to name a few, have led to the popularity of non-invasive imaging with venous duplex ultrasonography. Other modalities for detection are conventional and flow-sensitive magnetic resonance imaging or venography, respectively. D-dimer assays must also be included in the list. D-dimers are the byproducts of the degradation of cross-linked fibrin by plasmin. When measured with ELISA, D-dimer sensitivities reach as high as 96.8%. However, it is very nonspecific, with specificities as low as 35.2%. Elevated D-dimer values are associated with postoperative states, malignancy, infection, and trauma, leading to an insignificant utility in the surgical population. In regards to diagnosis, nomenclature is important. The name superficial femoral vein is not recognized as an anatomic name anymore due to the confusing nature among clinicians. As depicted here, the common femoral vein branches into the deep femoral vein and the femoral vein, which then leads to the popliteal vein. Classically, DVT is divided into an infrapopliteal or calf vein thrombosis and a proximal DVT, which was any DVT above the popliteal vein. More recently, the American Venous Forum and the Society of Vascular Surgery advocate for a new classification of DVT in their published guidelines in the May issue of the Journal of Vascular Surgery. Their Grade 1A recommendation is against the routine use of proximal venous thrombosis in favor of more precise characterization of thrombi as involving the iliofemoral or femoral popliteal venous segments. Current medical, surgical, and catheter-based therapy. This is a picture from one of our family hiking trips up in Maine. The first half of the 20th century was filled with landmark reports advancing therapies for venous thrombosis. The fibrinolytic effect of streptococcus was first described in 1933 by Tillett and Gardner, and heparin was first used successfully in humans in 1937. Hungarian Dutacus was the first to publish the use of low-dose heparin for DVT prevention in his 1950 JAMA article. And research by Tillett and Associates on the beneficial effect of streptokinase in venous thrombosis, published in 1955, started an era of thrombolysis in the management of acute venous thromboembolism. The first attempts at venous thrombectomy date back to 1926, when Basset performed a thrombectomy in a patient with axillary vein thrombosis, and the technique of surgical thrombectomy was first described by Leriche and Geisendorf in 1939. Anticoagulant drugs such as heparin, low molecular weight heparin like Lovenox, and warfarin are the mainstays in the management of DVT. In review, heparin's mechanism of action is the inhibition of thrombin and activator 10 by binding antithrombin 3. Warfarin inhibits vitamin K-dependent gamma carboxylation of coagulation factors 2, 7, 9, and 10, as well as protein C and S. And finally, Arixtra is a highly selective factor 10 inhibitor with an affinity for antithrombin. Their specific use will be further expanded upon in the current 2012 management section. So when a deep venous thrombosis occurs, the goals of therapy are pretty simple: to prevent the extension or recurrence of the DVT, to prevent a pulmonary embolism, and to minimize early and late sequelae of DVT, such as post-thrombotic syndrome. The options for early removal of an acute thrombus in the iliofemoral veins are catheter-directed thrombolysis, percutaneous mechanical thrombectomy with or without thrombolysis, and finally an open surgical thrombectomy. This is a summary chart of the first several trials of catheter-directed thrombolysis. These were using urokinase before it was removed from the market in 1999. Urokinase has been replaced with alteplase and reteplase with similarly good results. As you can see here, there was a good initial success rate between 79 and 84%. Complications listed, the two major ones are major bleed and intracranial bleed. And in this institution, we have strict protocols for blood pressure control after noting a number of intracranial hemorrhage complications in patients with severe hypertension and undergoing catheter-directed thrombolysis. Dr. Agel and Stoner, members of the vascular surgery department, published their results in the Annals of Vascular Surgery 2 years ago regarding these complications and the strict management of hypertension in patients undergoing thrombolysis. Camarada et al. In 2000 constructed and validated a quality of life questionnaire comparing the results of patients treated with either catheter-directed urokinase for iliofemoral DVT to those treated with anticoagulation alone. Patients with successful lytic therapy reported significantly better outcomes across all measures seen in the table, which included a health utilities index, treatment satisfaction, health distress, and just overall symptoms, as seen here. Due to the lack of randomized controlled trials between catheter-directed thrombolysis and anticoagulation alone, there are no clear-cut indications for catheter-directed thrombolysis. Current recommendations state that catheter-directed therapy is indicated in a select group of patients with greater than 1 year life expectancy, good functional and ambulatory status, that have extensive clot burden in the iliofemoral venous system with an acute presentation less than 14 days, as well as limb-threatening ischemia such as Phlegmasia, Cerulea, Dolens. Contraindications for thrombolytic therapy include a recent less than 2 week invasive or surgical procedure, or prolonged, noted at greater than 10 minutes, cardiopulmonary resuscitation, known bleeding diastasis, pregnancy, a recent stroke, active peptic ulcer disease, and uncontrolled severe hypertension. Percutaneous mechanical thrombectomy is an additional tool that can be used in DVT treatment. There are several devices on the market, and above is just one example. This particular device is a hydraulic recirculation device generating high-pressure jets, which creates a hydrodynamic vortex to allow for the clot to liquefy and be aspirated. There are no randomized controlled trials comparing this therapy. However, there is one 2011 systematic review encompassing the 16 retrospective studies on this therapy. Although there were few complications noted with symptomatic pulmonary embolism rate less than 1%, and the author stating it was safe and feasible, there's little evidence to support its use over catheter-directed thrombolysis. And currently, in most cardiovascular centers, its role is used in combination with thrombolytic therapy. Open surgical thrombectomy serves in a backup role for DVT intervention. Indications for open thrombectomy are patients in which catheter access cannot be achieved, thrombus removal or dissolution is unsuccessful, or concomitant anticoagulation is contraindicated, such as an iliofemoral DVT in a young peripartum woman. The surgical technique in a primary iliofemoral DVT involves a veinotomy in the common femoral vein, and a venous Fogarty thrombectomy catheter is passed proximally into the IVC. Upon completing the thrombectomy, a recommended temporary AV fistula is created, usually between the saphenous vein and the superficial femoral artery, to prevent immediate rethrombosis. Long-term results of surgical thrombectomy versus anticoagulation alone can be seen in 1997 prospectively randomized controlled trial seen from Sweden, where the thrombectomy had a highly significant difference in the number of asymptomatic patients versus anticoagulation patients alone at the early follow-up at 6 months up to 10 years at long-term follow-up, with a rate of 53% versus 23% respectively. Rounding out the discussion on interventions for DVT, inferior vena cava filters must be mentioned. Besides the numerous filters on the markets and the methods of insertion, the take-home point here is the list of absolute indications. By far, the number one on the list is a documented DVT or thromboembolism in patients with contraindications to anticoagulation. Other indications listed are recurrent thromboembolism despite adequate anticoagulation, complications of anticoagulation forcing discontinuation of therapy, and immediately after a pulmonary embolectomy. And this is a Christmas picture from a year ago with our latest addition, our third child, Owen. In this final section, I'll begin, I'll review the recently published guidelines in both the American College of Chest Physicians and the Society of Vascular Surgery, which were both released this year. In February 2012, the American College of Chest Physicians released their 9th edition of evidence-based clinical guidelines titled Antithrombotic Therapy and the Prevention of Thrombosis. It's a massive 801-page document with approximately 600 recommendations. I will in no way attempt to review even a fraction of these today, but merely highlight several pertinent recommendations to this talk. The following 2 slides is a complete table of contents list for the document. The 4 highlighted chapter titles are the sections from which I'll be stating the recommendations. The American College of Chest Physicians grading system classifies the recommendations as strong, grade 1, or weak, grade 2, according to the balance among benefits, risks, burdens, and possibly costs, and the degree of confidence in the estimates of the benefits, risks, and burdens. The system classifies the quality of evidence as high, grade A, moderate, grade B, and low, grade C, according to factors that include the study design, consistency of the results, and the directness of the evidence. I apologize for the next several upcoming slides, as I've listed the documented recommendation on the slide, but I promise I'll simply summarize the recommendation. First, for an acutely ill hospitalized medical patient at increased risk of thrombosis, anticoagulation with heparin, low molecular weight heparin, or Rixtra is recommended. A second and new recommendation for an acutely hospitalized medical patient at low risk for thrombosis, they recommend against pharmacologic or mechanical prophylaxis. Patients described as low risk were defined by the Padua Risk Assessment Model with a score less than 4 based on 11 common venous thromboembolism factors. The factors here are listed in the chart from their paper. As you can see, cancer, past venous thromboembolism, mobility, trauma, surgery, age, ischemic stroke, BMI greater than 30, with more recent evidence coming out about BMI as well, to name a few of those risk factors. For the same acutely ill hospitalized medical patient with an increased risk of thrombosis or a high risk of major bleeding, mechanical thromboprophylaxis with graduated compression stockings or intermittent pneumatic compression devices is recommended. For patients with asymptomatic thrombophilia, daily use of thromboprophylaxis is not recommended. In the section for the prevention of venous thromboembolism in general and abdominal pelvic surgery patients, patients above low risk for venous thromboembolism without high risk for bleeding complications are recommended low molecular weight heparin or low-dose unfractionated heparin with mechanical prophylaxis. The risk assessment in this section is based on the Rogers or Caprini score, who both assign point values to the venous thromboembolism risk factors. Of note, there were no new recommendations in this section. And then in the section on perioperative management of antithrombotic therapy, in patients with coronary stents receiving dual antiplatelet therapy, they recommend deferring surgery a minimum of 6 weeks after bare metal stent placement and 6 months after drug-eluting stent placement. And for those who require surgery within those time periods, continuing all antiplatelet therapy up until surgery instead of stopping a week before. In an isolated distal lower extremity DVT, with their definition of a DVT of the calf being a DVT of the calf involving the perineal, posterior tibial, or anterior tibial veins without involvement of the popliteal or more proximal veins, the following management is recommended. For severe symptoms, treat with anticoagulation for 3 months. For an asymptomatic, mild, or moderate symptoms, no anticoagulation is immediately recommended, but intermittent serial ultrasounds for 2 weeks to check for clot extension is recommended. If there is extension, treat for 3 months. Otherwise, no anticoagulation is recommended. They clearly note if clot extension has not occurred within the first 2 weeks, it is unlikely to occur. For proximal lower extremity DVT, treatment is with anticoagulants for 3 months. In the acute setting, they recommend several anticoagulants such as dalteparin, tenzaparin, Rixtra, and Lovenox, with conversion to long-term treatment with warfarin. They clearly state routine use of thrombolytics or clot removal interventions is not recommended. However, when dissecting this recommendation out in their article, They do agree that certain patient populations, as I previously mentioned in the indications for thrombolysis, do benefit from intervention therapy. Again, the length of time recommendation for this anticoagulation in this group is 3 months in general. Finally, I did want to mention the recommendation for upper extremity DVT, as the majority of this talk is focused on the lower extremity. If the DVT involves an axillary or more proximal vein, anticoagulation of therapy alone is recommended for 3 months. If the DVT is not associated with a central venous catheter, anticoagulate for 3 months. If it is associated with a central line, do not remove a functional catheter, start anticoagulation, and once the catheter is removed, continue anticoagulation for a total of 3 months. As mentioned earlier, the most recent set of clinical guidelines for DVT management was just published by the Society of Vascular Surgery in this month's May issue of the Journal of Vascular Surgery. In their evidence-based guidelines on early thrombus removal for DVT, the authors used the same grading, recommendation, assessment, development, and evaluation approach for their treatment recommendations. They made 14 recommendations total, with the exception of DVT anatomic terminology. All SVS recommendations support and reinforce the data and recommendations I have already presented today. I will review a few. They recommend using precise terminology to characterize the most proximal extent of the venous thrombosis. For example, an iliofemoral versus a femoral popliteal DVT. They recommend early thrombus removal in patients with their first episode of acute iliofemoral DVT, symptoms less than 14 days, who have a low bleeding risk, are ambulatory with a good functional status at baseline. For an isolated femoral popliteal venous thrombosis, the recommended treatment is with conventional anticoagulation as opposed to thrombolysis or thrombectomy. Compared with standard anticoagulant therapy, catheter-directed pharmacological thrombolytic therapy is associated with a significant reduction in the risks of post-thrombotic syndrome, venous reflux, and venous obstruction leading to a first-line recommendation of therapy. As already mentioned, surgical thrombectomy is reserved for those patients who have a contraindication to thrombolytic therapy. Venous self-expanding metal stent therapy is indicated after venous thrombosis removal caused by an iliocaval compressive lesion. Stenting in the femoral or popliteal veins is not recommended. And finally, a standard course of anticoagulation plus knee-high compression stockings for 2 years post-procedure are recommended after thrombus removal procedures. So in summary, I talked about today why DVT is important in healthcare today. We reviewed the pathophysiology, risk factors, and methods of diagnosis. We discussed the current available medical, surgical, and catheter-based interventions, and reviewed just a few of the recently released DVT guidelines by both the American College of Chest Physicians and the Society of Vascular Surgery. I'd be happy to take any questions, and I appreciate your time and attention today. Thank you.